Good afternoon, everybody. I am Ángel Sánchez Recalde from Ramón y Cajal University Hospital in Madrid. This is the fourth webinar out of 5 webinars about physiology and imaging and coronary imaging. And I'd like to thank Abbott for sponsoring this, all of these webinars. And today is a pleasure and it's a great honor to have with us Dr. Elvin Keddy from the university, the Libre University in Brussels, in Belgium. And he is one of the biggest experts in coronary imaging, and he's the first author of the combined trial. It's a breakthrough trial, and maybe will change our clinical practice. And the topic of the title of the presentation is from ischemia to plaque vulnerability, and to change the paradigm shift. Is a great title, and thank you so much, Elvin. And then after the presentation, we will discuss a live case as always, and with the help of Elvin, I think we will treat, we'll do our best with the patient. Thank you so much, Elvin, and if you want, you can start your presentation.
Excellent. I hope you see my screens, and hello to Madrid, one of the most beautiful cities. And we are just all interventional cardiologists, and our interest is how to do the best job for our patients. And over the years, we have learned that physiology and how the imaging can also help in achieving that. So my presentation will be focusing on how to combine the tools we have in our Cathlabs to get the best for our patients. So I'm going to give you first some insights from the combined trial, where the idea came to that, what it showed, and where it's leading to. So I had a case, I was working in Rotterdam in the Netherlands before, and one of my people that was working with me, actually the mother of the lady that cleaned the Cathlab, was, she sent her mother to me, and I did a PCI on a myocardial infarction lesion, and I treated another non-culprit lesion. I wanted to treat that, but I performed an FFR into this diabetic lady, and years after, not even years after, within the same year, she came back with a myocardial infarction. What in the beginning we thought it was a stent thrombosis, because that's what we were fearing the most at the time, but actually was this FFR negative lesion that turned out to give a STEMI. And that made me think that maybe in some of these high-risk patients, particularly into the diabetic patients, we did not have the data of what the FFR gave. And we also did not know much about the natural progression of these high-risk patients. What we knew were at the time was only the prospect trial from Dr. Stone, and it showed already that a plaque cap thickness of what we thought at the time to be a vulnerable plaque was associated with high risk for future adverse events. However, I had the chance to go to New York, and they put to me they gave to me the possibility to analyze a prospect, particularly the diabetic patients, into the prospect. And what I already did at the time, I compared this acute coronary syndrome with versus without diabetes. And what we found already at the time was that if you see in the blue, the non-culprit lesions, so these lesions that were not even intermediate, they were less than intermediate on average stenosis around 30%. They had more events during the follow-up than the lesions that were treated. And not only, but we could see that already then by IBIS histology, we could see that the thicva lesions were associated already with high event rate at 3 years follow-up. So 1/3 of these patients had an event during the follow-up. And that was also, if you see the hazard ratio between diabetes and non-diabetes, the TICFA lesions in the non-diabetics were also associated with a higher event rate than the counterparts that did not have TICFA. So already we individualized TICFA as a higher risk lesion. However, the limitations of the prospect was that it did not have FFR performed, and the IBIS resolution is about 200 micron, where we know that the real TICFA is less than 65 or sometimes less than 75, depends how you look to that. So for this reason, I designed the combined trial somewhere in 2012 was the design. We finally managed to get the funds and to start this trial in 2014. And the design of it was that the hypothesis of it was that the medically treated diabetes patients with angiographically intermediate, but otherwise non-ischemic, so FFR negative coronary lesions will have significantly different clinical outcomes depending on presence or absence of plaque vulnerability features, or in other words, OCT detected thin cap fibroaderomas, with thin cap fibroaderoma carrying patients having the worst prognosis. We choose here to have, again, diabetic patients as they represent the patients to population with the fastest atherosclerosis progression. And this is the design of the combined FFR OCT, which was a prospective multicentric international double-blind natural history study. And also a lot of patients came from Spain too. The groups of Dr. Fernando Alfonso and from Dr. Escanet participated in this trial. And so what we did, we had all those lesions where we usually do an FFR, so with diameter of stenosis between 40 and 80. And we call those the target lesions, the target for our investigation. And depending after we did the FFR, if the FFR was less than 0.80, we revascularize those patients. So in this group that we call the group C, we did not have any remaining FFR negative lesions. But if they had an FFR negative lesion, then we performed the OCT and divided the patients into a group A that had no high-risk plaque, so no thin cap fibroaderoma, versus a group B that had thin cap fibroaderoma. The primary endpoint was where we powered the study. This was a natural history study, but we already powered it because we said we already predict that these thin cap fibroaderomas will have a higher event rate. So the primary endpoint we choose for that was cardiac death, target vessel myocardial infarction, and we're calling target vessel those lesions where we performed the FFR and they were negative. Clinically driven target lesion revascularization, so revascularization of this, what were baseline FFR negative lesions, and hospitalization due to unstable or progressive angina. Here we excluded, during the follow-up, we excluded the anginas that were coming from a known reason, like for example, restenosis on a lesion that was stent elsewhere. And this at 18 months in the FFR negative thin cap fibroaderoma patients, so the group B versus the negative FFR negative, but with no TICFA patients, the group A. We also had this key secondary endpoint where we compared the patients that had full revascularization of all lesions, so they did not have an FFR negative lesion remaining, versus the group with high risk TICFA, group B. And that's what we found. We had about 550 patients. Of course, in some we had to exclude because the imaging was not performed accurately. So we hold over about 300 patients with FFR negative and no thin cap fibroaderoma, about 100 patients with FFR negative and fibroaderoma, and about 100 patients that had all lesions were vascularized because they had an FFR that was positive. Now, we focused our first analysis between the FFR negative lesions with versus without thin cap fibroaderoma. As you could see, the baseline FFR PDPA was identical, as was also the FFR value between those groups. However, somehow the TICFA lesions, the only difference we see in the quantitative results was that the TICFA lesions tended to be longer. What we also found is that similarly of what we've seen in the histology studies, also here, despite the majority of the non-TICFA groups being lipidic plaques, the lipid arc was larger in the TICFA group. There was no revascularization. So the formation of new vessels, there were more macrophage infiltrations, there were more cholesterol cleft on this lesion. So they were clearly found that there were more inflammation into this group of patients. And that was probably derived, that's why TICFAs were formed through the lytic enzymes and ongoing inflammation in these lesions. And as we predicted, the primary endpoint showed that the events were predominantly focused in the thin cap fibroaderomas. So we can also say that the events were caused from the thin cap fibroaderomas, and that with almost 5-fold more than the patients without this TICFA, which behaved in a very, very positive way, so very low event rate. So we practically clustered the events in the TICFA. That's where they're coming from. As you could see, we did not have any death in that group, but all myocardial infarctions, all need for these revascularizations, which were mainly driven from these unstable presentation, unstable angina pectoris. Most of those led to these revascularizations, were driven by the TICFAs. So the combine showed for the first time that in the diabetic patients, not all, but 25% of the lesions have higher risk characteristics, or in other words, OCT-assessed thin cap fibroaderomas. The impact of those is strong. They are strong predictors of future MACE. And despite the lack of ischemia, the amplitude is strong. So 5 times more, not twice. We were predicting 2.5. We found 5 times. So this is an important amplitude. And the new insight we created that is that the ischemia and future adverse events represent, to a large extent, 2 separate concepts, which we mean that you treat ischemia, you will definitely reduce the chest pain, but you not necessarily reduce future adverse events. And therefore, these are 2 separate concepts. So we conclude that the combined FFR and OCT can improve the accuracy of high-risk lesion patient identification and therefore should be embraced. Now, I'm going on why they should be embraced and what do we have learned and where we are going to. So you know this plaque progression, we have first here the accumulation of the lipid at a certain point through ongoing inflammation. This plaque will become vulnerable and further on, these vulnerable plaques, we know that they will rupture. And actually, when they rupture, we'll have either occult or overt coronary syndrome. It means if it creates sufficient lumen narrowing and the patient will present with chest pain that is ongoing. So this is an acute coronary event with all the spectrum from unstable angina to non-STEMI or STEMI. But if these plaque ruptures and heals without creating an acute coronary syndrome, or the patient will not feel it, it will progress oftenly and lead to further scar formation with the reduction of lumen. And then these patients will present as stable patients or with stable or crescendo angina. And that's where we actually will often do an FFR to these patients. And as you know, the FFR, about 1/3 of it will be positive and will lead to revascularization, but 2/3 of it will be negative and will lead to medical treatment. Now, we know that medical treatment will give plaque stabilization. However, we also know that persisting inflammation will lead to vulnerable plaque, these vulnerable plaques will continue in about 20 to 40% of the cases. But we don't know what the relevance of it is. Now, let's go back to this rationale of the FFR. And you know that the FFR, I like the FFR on the FAME1 level when you have to choose between multiple vessel disease and which one to treat. And that it showed that compared to treating of all, it will get better results. And that's where I think the FFR stands even now. It will reduce the chest pain. However, the concept of mandatory treatment was thought was a change in the FFR concept and was tested with the FAME2, where they compared medically treated severe ischemia versus revascularization with stents of this. And as you could see, it did show that revascularization of these lesions improved outcomes, but did not improve myocardial infarction, did not improve death. It only improved urgent revascularization in about 20%. As you could see here, we're about 20% of patients compared to all the patients that actually had revascularization on the other group. So you could come to a conclusion that the results were driven from this 20% need of urgent revascularization. And is exactly what we saw again in this ischemia trial. Was based to show that it will improve outcomes. It didn't. The only thing we saw here was a 20% reduction need for crossover. So from all the patients we treated, only 20% really would need treatment based on chest pain. Now, if we look to the Gaussian distribution, so distribution of the frequency of lesions that after FFR measurements will have FFR, let's say from 0.50 to 1, you could see that those between 0.75, if you count well, will be about 20%. So this is exactly what we have already known. We treated 0.75 to 0.80 between we did not know this was a sort of a gray area, but actually the true ischemia is below 0.75. And this actually was nicely shown from Nils Johnson and Lance Gold in very nice meta-analysis, where if we look, the real cutoff was under 0.75, which exactly tells us this 20% of patients necessarily coming back. And if we're looking for even severer or harder outcomes, if you look for outcomes of MI, it will even be lower than that. It will be somewhere about 72 to 67. Now, looking back, why we are treating patients? We're treating patients not only to reduce chest pain, we're treating them also to reduce future adverse events. And let's go back to the 5 years of the FAME. The results were maintained, but you could see that after that, things were similar. But however, they showed that over 5 years, there was a reduction in myocardial infarction. And if you look carefully to these numbers, you'll see that if we say that the patients without stents had a myocardial infarction rate about 15%, those with stent had it about 10%. So we'll see a reduction with 1/3. So you'll ask, why do these 2/3 come from in the patients that were treated? And again, exactly the same thing in the ischemia trial. You'll have there 10% spontaneous myocardial infarctions, but you'll also have 7% myocardial infarctions in the invasive group. So the question is, are these unaddressed vulnerable lesions that were FFR negative? And these are exactly 70% because this is the math when we do FFR. So if we're looking and we're doing the FFR, you know that if you go and test 100 lesions, about 30% or 35% will be positive and 2/3 will be negative. So also 70% of, not all of these lesions are vulnerable plaques, but probably 70% of these vulnerable plaques relatively will also be left beyond. And that's what we probably see. So the conclusion that we can drag from here is that probably this is not just chance. This could mean that these 70% of untreated lesions are also causing infarctions, or in other words, infarctions can derive also from non-ischemic lesions. And this is a new concept. Now, is it me saying this, or are there other studies showing this? Absolutely yes. This is a beautiful study, a study that comes from a working group combined from Japanese and South Korean colleagues, not North Korean. And exactly as I showed to you, they looked to CT scan, and they looked to higher risk patients on the CT scan, and they took these patients also on the Cathlab and performed FFR after. So as you could see here, from almost 600 lesions tested, about 70% of them were FFR negative, and about 80%, 31% were FFR positive, exactly as I said to you before. And this is the distribution of the high-risk lesions, but I'll show you this on a better slide. If you see here, these on blue, the blue quadrants are more than three high-risk plaques characteristics for that lesion. The orange is 2 high-risk plaques. The gray is 1 high-risk plaque. And you could see here, these are lesions less than 60. These are lesions with FFR 61 to 70. And these are lesions less than 80. And these are lesions with FFR more than 80. So these are lesions were not treated. As you could see, the majority of plaque are in the FFR positive. But if you look to the absolute numbers, in percentage, the majority of plaques, as you see here, will be higher, of course, in the FFR positive lesions. But the absolute number of what you're leaving beyond of these plaques, you'll leave 20 plaques, you'll treat 20, and you will leave 40 plaques beyond. And these are the high-risk plaques. Now, what happens to these plaques? This is another way of showing it. Now, what happens to these plaques? If you see in blue, these are the plaques that were left untreated in the FFR negative patients. And these were the FFR positive patients treated already at 2 years. These untreated plaques gave you significantly higher event rates than the plaques that were treated because they were FFR positive. So again here, as I showed you from the prospect one, the majority of events originated from FFR negative lesions with high vulnerability features. Now, can we identify vulnerable plaque with OCT? Yes, we can, because we could see lipid, we could see microvascularization, and could see macrophages, and we could see the TICFA. So for the first time, we have a histological approach in vivo nowadays with the OCT. And actually, I showed you with the combined trial, but there has been also the CLIMA trial from Prati showing that these kind of lesions have a high event rates. Am I the only one saying this? No. Look at this group of Japanese, very beautiful, they have done great work on OCT, particularly Kubo, Akasaka, on working together with the group of Columbia and Gary Means. They looked to OCT detected ThinkUp fibroaderomas, and they looked at actually during the follow-up, their patients, the only patients that will have events where they have these plaques with lipid-rich plaques and ThinkUp fibroaderoma. You could have it also for TICFA alone, but lipid-rich and ThinkUp is actually what we're saying is plaque burden and is ThinkUp fibroaderoma. These are the higher risk lesions. And during the follow-up, 33% of these lesions led to an acute coronary syndrome. So it's a very high number. 1 on 3 will give you an acute coronary syndrome. So these lesions require treatment. There is no treatment that will lead us to an acute coronary syndrome for 1/3. Nowadays, the results with stents are very good. So also in our study, the combined trial, We had this on OCT. We looked, this is the outcomes based on lipid-rich versus non-lipid-rich plaque. If you don't have a lipid-rich plaque, you have an absolutely very, very good outcome despite being diabetics, where the events were mostly seen in the lipid-rich plaque. But if you split this further and you see lipid-rich TICFA versus lipid-rich non-TICFA and fibrotic plaque, the lipid-rich non-TICFA and fibrotic plaque has excellent outcomes, where it's only the lipid-rich TICFA having the real problems. So it's true that lipid plaques have a higher risk than the non-lipidic plaques, but this risk is mainly driven from the lipid-rich thin cap fibroateroma lesions, while the lipid-rich thick cap fibroateroma lesions have a very good prognosis. And the OCT is the only tool today that can detect thin cap fibroaderoma. So coming back to where we started, I can say that persisting inflammation and vulnerable plaques will lead to acute coronary syndromes. That's why physiology alone is not enough, and imaging should be considered. So the take-home message here is that the FFR-guided revascularization significantly improves symptoms of angina, however, is not sufficient for reduction of death or MI, and that the lipid-rich and TICFA lesions are at high risk for future adverse events independently from ischemia. Should we revascularize these lesions? No evidence yet. We hope to answer that question soon, because I'm proud to announce that I'm going to lead another new trial. It's going to be the combined intervene trial, where we're going to treat about 1,220 patients in a randomized basis. It will be the first trial that will randomize patients and treat them for vulnerable plaque. Will be going on in 4 continents and about 50 centers. So what are we going to do into this? So this global trial will look to patients with multivessel disease, so that has at least 2 lesions in 2 different vessels of more than 50% angiographic stenosis on visual estimation. This could have any clinical presentation, so you could have their acute coronary syndromes. We're aiming to have 25% people with MI, 25% of people with unstable angina, and 50% of the patients with stable angina. And we're also aiming to have 30 to 35% diabetes mellitus, representing the real incidence of diabetes in the real world. What are we going to do? On one arm, the conventional arm, we're going to have the FFR guided revascularization. We're going to perform there also sham OCT, so the patient will not know in which group they are. And in this group, we'll treat patients as same mandates. So less than 0.80, we'll go for PCI. More than 0.80, we stay out of it. We treat them medically. On the experimental arm, we'll also perform FFR and OCT. And here, as I showed you, we'll only revascularize based on FFR lesions that are less than 0.75, because I just showed you that this is a real cutoff value. And lesions that are more than 0.75, we'll revascularize them if they present a TICFA, a plaque rupture, a plaque erosion with thrombus, or they have a plaque erosion in a minimum lumen area less than 2.4. If they have this vulnerability criteria, we will treat them. And when I say we'll treat them, we will stent them. And on top of it, we'll stent them OCT guided. While if they do not have this, they will be treated medically. We believe this will reduce the event rate with 50%. And the primary endpoint will be a revascularization. We were testing 2 different revascularization strategies. So the endpoint is cardiac death, any myocardial infarction, or any clinical driven revascularization. So, well, thank you. This was my presentation.
Okay, thank you, Elvin. It's a very nice presentation. And I think maybe we have a lot of questions. Are there any questions for the audience? Nothing. Okay, Elvin, I have a lot of questions. The first question is, now we can assess, we can identify vulnerable plaques And what is your preferable imaging technique to assess these plaques? OCT, NRS, IBIS, or histology with IBIS? What's your preference? Is OCT?
It's not my preference. It's the only possible. At the moment, if you want to see what we call TICFA, so what Reno Birmani and her group called a thin cap fibroadenoma, it needs to have lipid. It needs to have a thin cap fibroadenoma of less than 65 or 75. You have to see macrophages. You have to see neurovascularization and cholesterol grafts. So the only tool that gives us the possibility to see this all is OCT at the moment. There is some work about OCT and NIRS together that could improve that, but at the moment, the OCT is the only tool. So
totally agree.
It's not my preference, it's the only possibility.
Yes, it's true. And your another question is in IBIS or in OCT, but mainly in IBIS because we are using IBIS for a long time. The results in terms of mortality and events with IBIS, we decreased the cardiac events. And do you think is why with IBIS we assess better the lesion and we implant a longer stents to cover more plaque, and maybe we cover also a vulnerable plaques? What's your opinion about this?
I'm sorry, I didn't understand very well. So your point is that IBIS
my question is
procedure?
My question is with IBIS we can decrease the mortality and the events using IBIS. And my question is, do you think what is for with IBIS we use more, we use longer stents and we can cover more plaque, maybe a vulnerable plaque inside the stent, or we choose better the stent? Well, what's your opinion?
Yeah, I think it's all of this. I think that imaging in general allows you to do better work than angiography because you'll see exactly your landing areas. You'll see if you have dissections, which you eventually could see with IBIS. You will see taking some more plaque eventually, particularly what you think could be lipidic plaque or plaque burden. You could more accurately size your stent. You could not only axially, but also longitudinally. And of course, you could do that with IBIS. With OCT, it becomes even more easy. You don't even have to think about it. Machine will give you all those details. And I think that IBIS requires, I like IBIS also. IBIS requires some learning for operators to use it. OCT is so simple that you just look to it and everything is so clear.
I agree with you, but there is more evidence with IBIS because we started to use IBIS before OCT. But I agree with you. And another question is non-invasive studies and invasive studies. Also, when we have ischemia, ischemia is related with mortality. And then maybe ischemia is related also with high-risk plaque, with more plaque burden, with maybe calcium nodules, with minimum lumen area. What's your opinion? We treat ischemia maybe is related not only with the stenosis, but also is related with high-risk plaques. What's your opinion?
Yeah, it's. I think I just also try to show that during the presentation. As lesion progresses, is a continuum of rupture and healing. Rupture and healing. This means that there is continuous inflammation on this lesion. At a certain point, this will of course become ischemic. But there are some times that it's just necessarily not ischemic enough to call it ischemic with our criteria, but it's ischemic enough that in the way that if it will rupture the next time, it will cause you a real problem. So that's why we choose not any vulnerable plaque. We took vulnerable plaques with a diameter of stenosis already over 50% because, and within this group of patients, we think that having ischemia or not for future adverse events does not make any difference because the plaque burden is already there. So the next time this plaque will have an event or rupture or heal, that could lead to either myocardial infarction or progression of stenosis requiring revascularization. And if you have myocardial infarction and again ischemia, you could also die. So that's why we took this type of lesions.
Angel, I'm Marcelo San Martin. I have a question regarding the combined intervene trial. How many patients are you planning to randomize?
Exactly 1,220.
Considering a different approach, imagining you don't have the FFR and you are using OCT, for instance, for establishing severity or vulnerability of your non-culprit plaques. What are your cutoff for minimal luminal area? Because maybe you just needed the FFR in case of doubt with that minimal luminal area.
Well, the people from the Forza trial have done an approach like that to use quantitative, not qualitative, but quantitative measures of OCT compared to FFR. So that study has been done already and showed already that the OCT approach was positive. As I said, I don't really need a cutoff, because I'm more into the idea that it's a type of plaque and it's not the ischemia. We'll treat the very severe ischemic lesions independently from the plaque morphology, but actually for the lesions that are just over 0.75, we will treat the morphology types of plaques independently from the level of ischemia there, because we think that this burden could give you next problem. So I cannot tell you what the cutoff is. However, after we have done this trial, we will come back to that cutoff, but it will not even be necessary to find that cutoff, because I think your question is, why do you have to use two catheters at the same time? I think that Abbott is working on a catheter that does FFR and OCT together. So at the end of our study, we could compare those data and have one catheter that does both measurements.
Wonderful. We don't have any questions from the chat.
Yeah, I've got another question. Talking about the combined intervene, one part of the patients had acute coronary syndrome. And as part of the study, you do FFR and after OCT, no? Mm-hmm. What do you think about the use of FFR in acute coronary syndrome? Do you think is useful or not?
We know that it's not that useful, because there has been there was a study also published, but also it's in New England, but also presented at the ACC last year, that showed that actually FFR guided revascularization of the non-culprit lesions versus angiography did not show any difference. In fact, they revascularized the lesions that they found that were angiographically severe, and that went quite well. So it's not the question FFR guided versus medical, it's treating all that's more that's severe there versus FFR, and show that what's more severe was better. So I think there is not much use of FFR in acute coronary syndromes. It's more use of morphology lesions. So I think that's also why we're taking these lesions, because we want to show that these lesions, despite not having severe ischemia but having vulnerable plaque, will lead to a better outcomes if we treat those.
Okay, thank you very much.
Okay, and then Anna, we'll present the case.
Yeah, the case of today. The case of today, is a 56-year-old male with past medical history of hypertension, dyslipidemia, and prediabetes. He was admitted last Saturday with a myocardial infarction. You can see here the electrocardiogram. And this was the coronary angiography. You can see the culprit vessel was the right coronary artery. And here, quickly, I will show you the result of the intervention. It was deployed and stent a science 3.518 and was post-dilated with a non-compliant balloon 4 millimeters. Okay, and this is the left coronary tree. We've got intermediate lesion in the circumflex artery, as you can see here, and a severe lesion, angiographically severe lesion in the mid-LAD, and another at least moderate lesion, little bit more distal. And now Angel, I think he's going to show us the result.
Okay, and then I'll show you the result, because the lesions in the lady were very severe, and we treated with pedalation with a balloon and then a stent. The result was good. And now we will show you later. Now we did a pressure wire, and the RFR, the non-hyperemic arrest, non-hyperemic index, is normal. Is 0.94. The lesion of the circumflex is negative. And then we are going to do the OCT in order to treat or not to treat. And we will show you in a few seconds the OCT. In the meantime, Elvin, do you think what's your opinion? Do you think it's possible to translate the results of your trial combined to non-diabetic patients?
Sorry, I was muted. I think so, but you're going to need a much larger number. You're going to need a 2.5 number of these patients. So if you have shown that in, let's say, you needed 100 to show it in diabetes, you're going to need about 250 to 300 to show it in non-diabetics.
Angel, I have a question, not from the chat, but from myself. Just many colleagues that are watching us could argue that this patient has already an RFR, which is negative. So leave the circumflex alone. So it's up to you and to argue that on the basis of morphology alone, as we have nicely seen in this presentation, that we should put a stent in this patient, which I believe it's the answer is yes. If the minimal luminal area it's small, we have a TIGFA or lipid arch and monocytes, etc. But let's see what's our expert opinion.
Now we're doing this. Can you see the screen of OCT, Elvin?
Yeah, I can see.
Yes,
I can see. So going from distally to up.
This is normal. Yeah, this is a normal artery.
Yeah.
We are going moving
there
to
where the plaque begins.
Part.
A very tight stenosis there.
Fibrotic. This is still fibrotic. Here you are coming into lipid plaque.
This is a lipid
some
plaque,
microcalcification. Still. Okay. So now, yeah, here this part. Yeah. Sorry, you need to. Now this part is again normal with some calcium, but this is that osteal lesion, I guess, right?
Yeah, but this is not significant.
No.
The osteal lesion.
No. So if you go down there, this could be a yeah. Can you? So I think this is a bifurcation with the marginal.
Yes.
And I think if you go close to that bifurcation, you might have some thin cap fibroaderoma. I don't know if you, go a bit down.
No, but
more down, distal. Yeah, here also you could find that upper part in that about 3 o'clock. Here, for example, yeah, if you could measure this, you can enlarge and measure a little bit further. This could be a maybe just not enough, but you could need to find the thinnest plaque there and the thinnest cap and then there measure.
And this is the
This
$1
looks like a
million question.
little rupture if there is no side branch. If on angiography there is no side branch, this part looks like a
So in this case the plaque is a vulnerable plaque. It's a lipid plaque with we can see the macrophage, we can see the calcium, a lipid plaque. What's your opinion to how to treat with
But
a
I don't
stent?
know. I don't think this is the thinnest part of the cap. I don't think this is the thin cap yet. I think this is still a thick cap.
No, but it's more distally. We have to
I think this looks like a rupture plaque even. Is that?
more distal.
No, there you just crossed it. You just crossed it. There are signs of vulnerability on this plaque. There you go to 3 millimeters, 2.5, 2.2. This is a severe plaque. I personally would stent this plaque.
Yeah, more distally.
Yeah, but it's still small enough.
This is calcium. This
Yeah,
is the
here
lipid
it becomes
plaque.
good enough. So I would treat this plaque. Yeah.
Yeah, I agree with you. I agree with
Again, not based on what I have shown. My opinion, I had opinion, but that's why we're doing another randomized trial just to show that it is worth to do this. But we don't have yet the evidence. Based on Forza criteria trial, you could still stent this.
Want to be distal? Yeah, I agree with you.
Forza trial, for example, would say stent this too. Because I think I saw a couple of small plaque ruptures here and there also. Protrusions, here is definitely a thin cap fibroaderoma where you were. So. I'll try to land really ostially on the circumflex. There you had a good landing area.
More proximal, more proximal.
Yeah.
We'll have to cover from the distal part to cover this area, which would you think this might be a thick
normal segment in the artery? I think it's more proximal. More proximal.
Here.
I'll go close to the 50 there. A bit more. Over the bifurcation. Over
27 millimeters. Over the bifurcation.
There, more or less. That's where I'll come.
Yeah. No, pasaría otro día. Okay. We will do this. But I think
me parece que hay una diferencia de calibre importante, ¿no?
I think you have not a big difference of caliber, only half a millimeter. I think distally it was about 3. You'll see it's about 3 there. No, sorry, 2 point. If you go a little lower, there it'll be 2.2, 2.2. I think in this case, 2.2. Something like this. Yeah, 2.3. So you know that I don't know what kind of stent you're going to use, but you used science before, so science will allow you to go up with at least 1 millimeter, but sometimes 1.5 millimeter. So 2.5 will be the stent that I'll choose here for the length that you have, and then post dilate to 3.5.
Mucha discrepancia de calibre.
It's a beautiful case.
Yes, because it's the FFR negative and a vulnerable plaque. Yeah, it's a beautiful case. And then in the meantime, and we are waiting for the result of the combined intervene. In these cases,
we have to start yet.
Yeah, but I think your opinion is always to treat with a stent.
Yes. In this study, we'll do stent because, but I mean, in general, sometimes the beauty of OCT is that it shows you sometimes that the extension of lesion is so big that you can easily also, if you see that you have very long lesions and a lot of disease, you could move also to surgery. It's why imaging is so nice. It gives you information that you don't have otherwise.
Have problems with the guide wire because we lost the pressure wire and we had to change the wire. And this is a very bend. This a tight angle in the left main and the circumflex.
So, Elvin, this is why I was arguing against the FFR, because we've seen in this demonstration that some patients with FFR negative could have very severe stenosis. And if I had to begin this case with, I would do exactly the same with the OCT guided LAD, but also use the OCT for the left circumflex, and I would not need the FFR. So, what are your thoughts about that?
Yeah, of course. I think I fully agree with you. And the point is that the reason we are using FFR again in the combined intervene is to sometimes take also lesions that are severe, based on even if they are calcified, but they are super severe, then the patients will have chest pain, and then you need to open this. So, but I think that OCT in the end will be sufficient for the majority of the lesions. So basically, if the OCT, you could also switch things. First use OCT, and if you have already enough criteria, then you go on and you don't need FFR. And basically, if you have a very, very severe lesion, the OCT will not even pass, then you also need to treat. So,
of course, but it was about intermediate lesions in acute coronary syndrome patients.
Yeah, then I think that OCT could do the job alone. And as I said, by the time we're there and treating the patients this way, the OCT could also give you the value of the FFR or RFR.
So Angel, Jose Luis, tell us what you're doing.
No, we are crossing again the lesion with a normal guide wire, and then we are going to implant the stent.
Okay, and it's science?
This is a science 2.75, and the length is
28.
28.
I saw it here.
Are you planning to predilate?
No, but no. Maybe do you see a lot of calcium, or you see calcium too?
No, actually not, but mainly because it's a very tight angle that you could see that when you put the wire.
Yes, I know.
Do you have any difficulties crossing with the OCT catheter? Not a lot.
Okay. Well, what wire are you using?
Sorry, then?
The guide wire is cyan blue.
The guide wire. The wire is cyan blue, and the catheter is EVU 4 6 French.
Piece of cake.
More distal.
Okay.
I think.
Okay. Yo creo que ahí, ¿no?
Good afternoon. I'm Luisa Salido, and I have a question for you. Do you think all the morphologies has the same risk, the vulnerable plaque? The thin cap is the same as thrombus with erosion with thrombus, or we should treat all these morphologies, or we should treat all the thin caps that we saw?
Is this for me, the question?
Yes. Yes.
Okay. I think, as I said, I will treat all the thin cap fibroaderomas over 50% diameter stenosis. I will treat all the plaque ruptures that still have a diameter stenosis more than 50%. And over the plaque erosions with thrombus, not all of them. But if you have plaque erosions on lesions that are with very severe area of stenosis and with a minimum lumen, then there is a chance that it will be repetitive, and only those ones from the plaque erosions I will treat.
Okay, thank you.
This is the result of the stent. What do you think? We are planning to post-dilate the proximal part of the stent, because with OCT, this part is about 3.2 millimeters, and then we are going to post-dilate and then to do the final OCT.
Distal, it looks great to me. I think we know that proximally you need to post-dilate.
Yeah.
And then maybe you could do a final run. You have the OCT there anywhere. So
Don't know, Angel, if you can include the final run, this ostium of the circumflex.
The ostium is a spasm. It's not a true lesion. It's with wire and with the
it's a kinking indeed.
It's a kinking. And this is negative. This RFR is negative. And Elvin, talking about the OCT and the characteristics of vulnerability, the TICFA, do you find TICFA less than 65 microns? Is the definition?
Yeah, we took 75 in the new trial because 65 comes from histology. And you know, when you do histology, the lesion tends to shrink a little bit, about 15%. So if you add 15% to 0, 65 comes to about 75. And that's what we choose this time. Could have been 0.80, but you know, we're going to do a post hoc analysis to see where the real cutoff will be.
And what other different characteristics of vulnerability are you taking into account? The arch of the lipid arch, of the presence of macrophages, or which features?
The other features will be actually real plaque ruptures with severe diameter stenosis, because we have already more than 50 here. But you know, at the actual state we could not think of treating patients based on macrophages. I don't think that a lot of people are able to see them, even the experienced operators. There is a lot of discussion about this. So at this moment, we'll have to keep the thing simple. We will learn, there will be better analysis of the data. And based on what we learn, we could in a future moment take other characteristics or have artificial intelligence doing this sort of analysis. But at this moment, already you see, you need to scroll this lesion now to see where this is. So for the real day practice, we need to keep things easy. And we're looking now only for TICFA. We know that TICFA has also those kind of lesions. And so TICFA plaque rupture and eventually thrombus with in a very severe lesion.
Totally agree with you. Now we are going to do the final OCT. We have only 4 minutes to finish. I don't know if there are there any questions from?
No, just a quick reminder that a plaque can be modified by medical treatment. It's fair to say that in some studies, especially very recent data from the world of PCSK9 inhibitors, have shown us that many of these TICFAs or very rich lipid plaques can be modified without putting a stent. So it will be interesting to see, Elvin, your trial.
I absolutely believe into this too, but you have to realize that this thing costs about I don't know how many thousands a year. So it's available, but in a way it's not available because the massa of people on the world, and we're not talking about the rich European countries where even here it's not reimbursed for everybody, will not have this. So
yeah, that's true.
In the real
at
world,
least in patients that do not have a very severe or very tight stenosis, if you have a room for optimization of lipid therapy, for instance, and also prolonged antiplatelet, double antiplatelet therapy could be an option. But I'm only arguing in patients without severe stenosis. That's my point.
yeah, absolutely.
Elvin, I'll review the OCT because it's important because I think the result has to be optimized with OCT.
It looks good.
We are treating a non-limiting flow. It's important to optimize the result with the stent. Distally, there are no dissections. The expansion of the stent looks like good. And the position also, I think, is good.
It's good. I only want to see the proximal part.
Yeah.
Proximal edge where it lands. Lands good. I don't see anything there.
Yeah.
It's good.
Yeah.
I think if you take off the wire, you will see that artifact that you have there.
Yes,
and it will be beautiful.
Yes. Okay. We are going the final angio after nitro. Get nitro listen.
Looks beautiful.
We only have 1 minute. I think it's a beautiful case to support your study, the combined study. Yeah.
Absolutely.
And we are waiting for the results of the combined intervene because it's the $1 million question is how to treat these patients with medical therapy, with a metal stent. Then a few years ago we had absorb stent, but nowadays we don't have an absorb stent, and it's difficult to implant another type of stent than a metallic stent. I think it's a very good result.
Look how beautiful it is.
Yeah, yeah. Okay, thank you so much. I think it's 3 o'clock. I think it's time to finish. And thank you so much, Elvin. It was a great pleasure to discuss this case. And your presentation was very nice. And thank you so much. And see you in the next webinar. Thank you so much, Elvin.
Absolutely.
Bye.
Thank you.